To undertake the study, we looked at a number of different groups of women. We had women who were still living in Bangladesh in an area called Sylhet in the northeast of the country, from where many migrants to Britain come. We looked at women who had migrated to England from Sylhet as adults, that is, they'd spent their childhoods in Bangladesh. Then we had a group of women who migrated as children to the UK, so they'd been born in Bangladesh, but then they were raised in the UK. And we had a comparative group of white women of European origin, and all of these women were aged 35 to 59. To measure ovarian reserve, we looked at 4 different hormones: AMH, inhibin B, FSH, and estradiol. And we found that our hypothesis was upheld, and so were our predictions, namely those women who had grown up in Bangladesh had a significantly low ovarian reserve as measured by these different hormones, compared to women, even though they were Bangladeshis, who'd spent their childhoods in Britain. And the women who had spent their childhoods in Britain had an ovarian reserve that was comparable to the women of white European origin. This study is one of a whole suite of different pieces of research that we've been undertaking with migrant Bangladeshis to look at the impact of early life development on reproductive function and other areas of development like adrenarche. So you may ask, what is it about the environment in Bangladesh that's important in determining or influencing these results? The groups of people that we study are middle-class Bangladeshis. They do not suffer from nutritional stress, they don't have to work very hard in anything like agricultural labour, they are able to own land, they have servants in their homes. Bangladesh has a much higher rate of infectious diseases than you would find in a country like the UK. It's a semi-tropical country. The level of healthcare is not as good as you would get in the UK. And we do know from a lot of the data that we've collected that the Bangladeshis are exposed to a greater number of infectious diseases during childhood. It has come out as a significant predictor in some of our studies. We also use a perspective drawn from what's called life history theory in biology that argues that as individuals are going through their life course, they have to apportion their resources, their energetic resources, across 3 different domains, that is growth, maintenance, and reproduction. And so for those individuals who are fighting infectious diseases, they have a lot less of their energy to put into potential reproductive function even later in life than other individuals who are more fortunate in not being exposed to many immune challenges. It's not enough to just compare ethnicities of people when you're considering differences in ovarian reserve or potential differences in how women might respond to treatments in fertility clinics. You have to also look at many other factors. You have to look across generations, and not just generations, but even within a first generation where somebody might have spent their childhood could be a really significant predictor of how they might respond to fertility treatments.